Hello, everyone. I'm Professor Stephen Chan from the Oncology Department at the Chinese U Hong Kong. I would like to thank the Roche for the invitations for me to speak on this topic titled Impact of the IMbrave150 on the advanced HCC treatment landscape and how does it improve our patients' outcome. In the next 35 minutes of time, I will firstly again go through the data of the IMbrave150 in HCC. In the second part, I will talk about its clinical impact on the advanced HCC. And the third part, I will talk about its impact on other stage of HCC before I give you the conclusions. So before I talk about the IMbrave data, I would like to recap or give a quick summary of the past 20 years of development of systemic therapy for liver cancer. We learned that for the past 20 years, for cytotoxic chemo, no matter is a combination of different cytotoxics or in combination with sorafenib, is not working very well in advanced HCC because of toxicity and the comorbid cirrhosis. And also we learned that when you talk about TKI, no matter it's a combination of TKI or the combination of the TKI with TACE, these approach does not produce additional or synergistic improvement in outcome of advanced HCC. And then also we learned that unlike breast or lung cancer, which there's a biomarker-driven approach, biomarker-driven approach is not working very well in HCC, either because the biomarker is very few or is not a driver mutations. The typical story include the FGFR inhibitor or the MET inhibitors. And then before I talk about the TASL story, I'm sure all of you have seen these slides many times. I would just like to recap the concept that for this combination, it not only works on the anti-cancer part, but also there's a strong rationale. The addition, the regimen could actually improve the immune environment and improve the immunoclearance of the tumor. And this is why we have these IMbrave150 study. Based on the initial very promising phase 1-2 data, this trial was designed to randomize mainly the patient with advanced HCC, first line setting, good performance status, Child-Pugh class A liver function, and then with different stratification factor, randomizing patient to the experimental arm of atezolizumab, 120 milligram every 3 weeks, and the bevacizumab has made use of a relative higher dose, 15 milligram per kg every 3 weeks, versus the sorafenib, which is the control arm. It's an open label study, so a patient will be treated till either a loss of clinical benefit or unacceptable toxicity. The primary endpoint are two. One is the overall survival, another is the PFS based on the independent review RECIST 1.1. So probably most of you are aware of this study declared positive because initially because of the significant improvement in the median progression-free survival, 6.8 months versus 4.3 months. And this is have a hazard ratio of 0.59 and the P value lower than 0.001. At that time, the overall survival has not yet matured, but subsequently, we also know that when they have more data, more event updated, the median overall survival of atezolizumab was 19.2 months versus the sorafenib, which was 13.4 months. The hazard ratio was 0.58 and also with statistically significance. And of remark, the estimated 1 year survival rate was over 65% in the atezolizumab group, while in the sorafenib arm is around 55% of the patients. Again, this represents a significant proportion of patients survive much better than the sorafenib in the atezolizumab and the bevacizumab group. And also when you look at the quality of life, sometimes we're worried that the combinations may cause more problem in patients with advanced HCC and cirrhotic. But again, interestingly, you could see that even you use a more aggressive combination than the single agent of the sorafenib, when you talk about the deterioration of the quality of life, again, this combination is much, much better than the sorafenib. This likely reflecting that although there may be slightly more toxicity related to this regimen, it's also preventing the patient from deteriorating of the treatment. And therefore, again, this confirmed that no matter in terms of length of the life and also the quality of the patients is also better for the atezolizumab and the bevacizumab arm. So what's the clinical impact? Now we have advanced with IMbrave data. Certainly it's a positive data. I think the most important impact is you could see after the release of the data of these IMbrave150 study, no matter it's the FDA response or the NCCN guidelines, and also the ESCO guidelines or the ELCA guidelines, all of these guidelines or approval basically endorse the use of atezolizumab and bevacizumab as the standard first-line treatment for patients with advanced HCC. Of course, we recognize that some patients may not be suitable for atezolizumab, like with autoimmune diseases or with varices problem. Then those alternatives will be the monotherapy, like sorafenib or the nivolumab. But most of the guidelines endorse this as a standard first-line agents. So what is another impact? Perhaps I talk about the subsequent lines of the treatment. I talk about the chance of conversion and the downstaging. You could see that this treatment, when compared to the monotherapy sorafenib, another feature is associated with quite a number of patients with good response. You could see that around 5.5% patient had complete response, the RECIST 1.1. And also close to 22% of the patients also had partial response. So making around 30% of patients could have a variable degree of shrinkage of the tumor. If you talk about the modified RECIST response, it's even higher. More than 33% of patients have response, either complete or partial response. And what will be the nature or the features of the response? We could take a look of these study which is a subgroup or post hoc analysis to characterize the response to the atezolizumab and bevacizumab versus sorafenib from the IMbrave150 data. In summary, the first part, you could see that they tried to look at the tumor size of the patients. You can see that, or the tumor number, you can see that the patients, when they have a bigger tumor or smaller tumor, they all have a response from the atezolizumab and the bevacizumab. And also for patients with a higher tumor number or lower tumor number, these atezolizumab and bevacizumab also respond better than the sorafenib. And also when you look at the depth of the response, you can see median percentage of shrinkage is around 40%. So actually it's quite a significant proportion of patients. And also you could see that the time and the durations to the response are around 7 months to the among those patients with CR, 7 months for the patient with atezolizumab and bevacizumab. And therefore, these highlight the fact that those patients, not only high proportion of patients with response, but also they can have a significant shrinkage of the tumor. And also the time to take to the maximum response also is quite reasonable, only 7 months. And this is another snapshot from another group in China. They're trying to show you that actually when patients are having the combination of PD-1 and other like TKI or VEGF, those patients could have a significant shrinkage of the tumor. So this is important, not only because it shrinks the tumor, but also could shrink the tumor to the degree that our surgeons could go in and conduct surgery on those patients. In fact, you can see that in these patients, after resections of the responding tumor, you could see that the tumor is completely necrotic, suggesting that the combinations could really help those patients. And also, I would like to share with you one of our case. This is a slightly different from the perspective, but again, it's the response that really help us select the patients. We have these patients actually initially had already undergone surgery, but subsequently he developed some peritoneal metastasis. So we have discussed this case in our tumor board. Of course, our surgeon could go in, but we are a bit worried that to resect those peritoneal metastases. But we are a bit worried that this patient may still behave very aggressively with multifocal diseases, and therefore we want to treat him or her with these systemic therapy. And we opted for the atezolizumab and the bevacizumab. And you could see that actually after 1 year, those peritoneal metastases responded. But then this patient actually have new splenic metastasis. This time is different. Although you can argue this patient, okay, have another site of progressive disease. But actually because the peritoneal metastases have been very well controlled by the combinational immunotherapy. And therefore this time, our surgeons are more eager to go in, and this patient actually have undergone the splenectomy and distal pancreatectomy. And this patient have survival more than 3 years as of now. So this is another example showing that sometimes when we give aggressive systemic therapy like the atezolizumab and bevacizumab, we could select the patients with relatively responding tumors and indolent tumors so that our surgeons could go in and give the maximal benefit to our patients. And then I talk about another impact is subsequent lines of therapy. We know that in the past, when we put the patient on sorafenib or lenvatinib, and also another TKI like regorafenib or cabozantinib, these will be a typical sequence. But nowadays, we know the first line have been changed from the atezolizumab, bevacizumab to our patients. So what will be the optimal second line treatment? The answer is we don't really have a high level evidence, unlike the sorafenib, lenvatinib sequence. So in this sorafenib, lenvatinib sequence, we know the survival is around 26 months. So this is one of the data. The first data is a real-world retrospective analysis of the patient who have failed the first-line atezolizumab and bevacizumab. It's a multi-center study in collaboration between the Korea, Hong Kong, and also the Taiwan group, the Singapore group. So we look at the effects, and you can see that the patients, when they put on the sorafenib or lenvatinib after failure with atezolizumab and bevacizumab, actually the median progression-free survival range from 3 months to more than 6 months, while the overall survival actually is quite more close to 1 year or even longer than 1 year. We could not run very detailed analysis to compare the two agents because of limited sample size and the difference in the timing of starting those agents. But this is a proof of concept study that the TKI, especially our use the old first line, like the sorafenib, lenvatinib, is a reasonable second line treatment after the failure with atezolizumab and bevacizumab. In fact, if you look at the EASL Physicians paper, similarly, although we are running, we don't have a really high level phase 3 data, it's generally endorsed that those patients on TKI or VEGFR2 inhibitor could be used as an off-label in the second line agents, while for patients sorafenib, lenvatinib, or those patients contraindications on the atezolizumab, then they would put on these other conventional second line or third line treatment. Lastly, is that we seldom look at the varices when we are treating patients with sorafenib or lenvatinib. But now we know that because of atezolizumab, there's a concern about the bleeding, especially from the esophageal varices. Fortunately, if you look at the adverse event from any cause, you could see that the number of events and also the type of events are actually, we don't see any new safety signal. We do see a small proportion of patients, only 5% patient grade 5 events, but most of the patients actually they don't have any significant problem from the atezolizumab. This is one of the common scenarios that we may have discussed, is that all patients likely require the OGD before the administration of atezolizumab and bevacizumab. If the patient have minimally elevated above surfaces of varices, usually they're considered small. and these patients are generally considered safe. While if the patient have, say, medium or large, i.e. larger than 5 millimeters above the surface, they're considered having a higher risk of bleeding from the atezolizumab and bevacizumab. In terms of the treatment, for those with small, usually we just observe and put on the non-selective beta blocker like propranolol. While if the patient have medium or large esophageal varices, usually they require both or the medical treatment and also the endoscopic variceal ligations. So these patients, medium large, usually they are not suitable for the atezolizumab and bevacizumab. They should not be started dose treatment until they are adequately treated. And finally, I would like to talk about the impact not only on advanced HCC, but also on the earlier stage HCC. This is a very classical BCLC treatment algorithm. Surgery for the BCLC-A and TAC for the BCLC-B, and the systemic therapy for the BCLC-C. And nowadays, because we have more treatment option for the systemic therapy, is there any chance that for a proportion of patient BCLC-B, they could be treated with these expanding systemic therapy treatment sequences? To put this into perspective, a group of HCC doctors, researchers have gathered in 2019 to discuss the changing paradigm in the treatment of the BCLC-B HCC with a view that we have more systemic therapy treatment options. And at that time, one of the concepts that we would like to introduce is the TAC unsuitable. So what is the TAC unsuitability? Basically, technically, you could still give TACE, but because the patients, either they have a high chance of not responding to the TACE, such as those patients with special morphology, massive infiltrative type, or those patients with multiple disseminated nodules or poorly differentiated histology, or the patient having a high chance of TACE failure or refractoriness. Like at that time, we put forward up to 7 criteria out, or those patients have a high chance of a deterioration of liver function. So these will be up, including the LB grade 2B, or a patient with tumor burden beyond up to 7. So in this patient, technically you could still give TACE, but better there's some data showing that when you give systemic therapy, actually you can preserve the hepatic function, you can improve the outcome of the patients, and also subject the patient to more subsequent systemic therapy. So when you look at the IMbrave data, again, you could see that in the BCLC-B patients, they also actually still benefit those patients with a hazard ratio of 0.65. It crosses 1 because of a smaller sample size. But again, this is a proof of concept that the atezobev, their benefits is not only limited to BCLC-C. So there's a chance that for a proportion of patients with high burden BCLC-B, we may also subject the patient to the atezolizumab and bevacizumab. And in fact, we know that there have been an ongoing, I would say, randomized control study known as the ABC HCC trial. It's an investigator-initiated study by the Germany group, but actually it's a multi-center international study. The experimental arm is atezolizumab plus bevacizumab, while the control arm is the TACE in BCLC stage B HCC. So this study will be very important because the result could potentially change our practice by suggesting that a proportion of stage BCLC-B patients may better be treated with atezobev instead of TACE. Another concept I would like to discuss about is the neoadjuvant treatment in HCC. We know in oncology, actually neoadjuvant treatment is no stranger. A lot of tumor actually they benefit from neoadjuvant treatment, like the breast cancer or those patients with rectal esophageal cysts. These could help us shrink the tumor, preserve the organ, or patient with biology, like with only limited liver metastasis. The upfront or neoadjuvant chemo could help render the hepatectomy feasible. And also rectal cancer, we can again preserve the anal sphincter. So in HCC, is there any chance that we give neoadjuvant treatment with a aim to reduce the extent of surgery, which i.e. we could preserve the hepatic function, or even we could render some borderline cases to become clearly operable. So this is some of the concept we may discuss in the future. And we know that there have been a number of neoadjuvant study ongoing, and hopefully in the next few years we will see the data. So ladies and gentlemen, I would like to give you the conclusion. Conclusion one is, I hope I have convinced you that the data of IMbrave150 have established the regimen of A plus T as a standard first-line treatment for advanced HCC. And the IMbrave150's data have clearly shown that these regimens featured by better PFS and OS than sorafenib, and also the quality of life of patients has been significantly improved. And also for the impact of the advanced HCC, no doubt the atezolizumab and bevacizumab approach regimen has endorsed international approval as the standard first-line treatment if there are no contraindication to the combination. Conclusion two is because of high response rate, the atezolizumab and bevacizumab could enable potentially downstaging of the advanced HCC to ablation or even for surgery. And also because of these regimen, it has made us to have a more collaboration with our GI or surgical colleague to streamline the arrangement of upper endoscopy for variceal screening. And I'm sure there will be new waves of clinical trials on evaluating the subsequent line treatment after failure with the A plus T. And also we know these advances, the IMbrave150, may also impact on the use of systemic therapy in intermediate stage HCC, or even it will lead to some potential use of neoadjuvant treatment in patients with early HCC, which is potentially or borderline resectable. So thank you very much for your attention. I'm pleased to address any questions in the Q&A session. Thank you very much.